Hello everyone and welcome to Blood and Hematology YouTube channel. Diagnostic criteria and blood and bone marrow morphology of acute erythroleukemia and acute megakaryoblastic leukemia are discussed in this video. Acute myeloid leukemia with predominant erythroid differentiation accounts for about 3 to 4% of AML cases, with higher frequency in the elderly. It should be noted that the FAB and WHO classifications have different definitions for erythroleukemia. The FAB criteria for the diagnosis of AML-M6 include: erythroblasts comprise at least 50% of bone marrow nucleated cells, and blasts comprise at least 30% of bone marrow non-erythroid cells. Based on the presence of a significant component of myeloblasts, there are two subtypes of acute erythroid leukemia in the WHO classification: acute erythroleukemia and pure erythroid leukemia. In acute erythroleukemia, erythroblasts comprise 50% or more of bone marrow nucleated cells, and blasts comprise 20% or higher of bone marrow non-erythroid cells. In pure erythroid leukemia, erythroid components, prenormoblasts and basophilic normoblasts comprise 80% or more, 50% or more, and 30% or more of bone marrow nucleated cells respectively. In addition, the myeloblast component is not significant. In the 2022 WHO classification, pure erythroid leukemia was changed to acute erythroid leukemia as a distinct AML type, characterized by neoplastic proliferation of erythroid cells and high prevalence of biallelic TP53 alterations. Acute erythroid leukemia diagnostic criteria include erythroid predominance, usually 80% or more of bone marrow elements, of which 30% or higher are prenormoblasts. In peripheral blood, dimorphic erythrocyte population, schistocytes, teardrop cells, basophilic stippling, Howell-Jolly bodies, and other inclusions are often present. Circulating erythroblasts are present in around half of patients and may show dysplastic features, multiple nuclei, and abnormal nuclear shapes. Circulating blast cells, myeloblasts, and micromegakaryocites may be present. Or rods, hypergranular and hyposegmented neutrophils and giant and hypergranular platelets also may be present. Peripheral blood film of a patient with AML-M6, showing anisopoikilocytosis and circulating nucleated erythrocytes. Circulating normoblasts in a patient with AML-M6. Peripheral blood film of a patient with AML-M6, showing an orthochromatic normoblast, a late basophilic normoblast, polychromasia, and a large platelet. Peripheral blood film of a patient with AML-M6, showing a myeloblast with or rod, an eosinophil, and a large dysplastic erythroblast. Circulating binucleated erythroblasts in a patient with AML-M6. Peripheral blood film of a patient with AML-M6, showing a myeloblast and two normoblasts with incomplete nucleus extrusion. Peripheral blood film of a patient with AML-M6, showing a normoblast with abnormal nuclear shape and an erythrocyte containing multiple Howell-Jolly bodies. In the bone marrow, moderate to marked erythroid dysplasia is particularly common, with erythroid precursors showing features such as nucleocytoplasmic asynchrony, nuclear lobulation, karyorrhexis, binuclearity, internuclear bridges, basophilic stippling and cytoplasmic vacuolation. Giant and multinucleated erythroid cells are sometimes prominent. In some cases, erythropoiesis is predominantly megaloblastic and in others, it is macronormoblastic. Dysplastic changes in granulocytic component and megakaryocytes may be present in around half of patients. Myeloblasts may show ore rods. Bone marrow film of a patient with AML-M6, showing erythroid cells with dysplastic changes. Bone marrow film of a patient with AML-M6, showing a proerythroblast with cytoplasmic vacuoles, a basophilic normoblast, 2 polychromatophilic and 3 orthochromatic normoblasts and a myelocyte. Bone marrow film of a patient with AML-M6, showing a giant and multinucleated erythroblast. Binucleated erythroblasts in a patient with AML-M6. In acute erythroleukemia, FAB, M6, myeloperoxidase and Sudan black B stains are positive in myeloblasts. Erythroblasts are positive for periodic acid Schiff stain, showing a diffuse or finely granular pattern with or without coarse granular or block positivity. Erythroblasts with siderotic granules and ring sideroblasts may be present. Erythroid cells express hemoglobin and glycophorin A antigens. They are negative for myeloperoxidase. Positive periodic acid Schiff stain in 2 erythroblasts. Acute megakaryoblastic leukemia, AML-M7, represents only about 1% of cases of AML in adults but 2 to 15% of childhood cases. AML-M7 shows a markedly increased incidence in children with Down syndrome. AML-M7 diagnosis requires the presence of at least 20% blasts, of which at least 50% are megakaryoblasts. Blasts demonstrated to be megakaryoblasts by immunological markers, ultrastructural examination or ultrastructural cytochemistry. In some cases, the diagnosis can be suspected from the cytological features when the blasts show cytoplasmic protrusions or blebs, or when blasts coexist with apparently bare nuclei, with large bizarre platelets or with more mature cells showing megakaryocytic differentiation. Sometimes the blasts cannot be distinguished morphologically from myeloblasts or lymphoblasts. In these cases, immunophenotyping and the megakaryocytic antigens analysis are usually required for AML-M7 diagnosis. AML-M7 blasts generally do not stain with myeloperoxidase and Sudan black B, but show activity with periodic acid Schiff. Megakaryoblasts are identified by immunostaining, using antibodies specific for megakaryocytic antigens such as CD41, CD42B and CD61. Megakaryoblasts are about 10 to 24 micrometers in diameter with high nucleus to cytoplasm ratio. The scant cytoplasm is basophilic, non-granular, and often with typical protrusions, blebs or pseudopods, from the margin. The nucleus is round to oval or kidney-shaped, with fine and delicate chromatin and few prominent nucleoli. Peripheral blood in AML-M7 usually presents leukopenia and thrombocytopenia, but a minority of patients may have thrombocytosis. There are blasts with pleomorphism, cytoplasmic blebs or pseudopods, and basophilic cytoplasm. Dysplastic and large atypical platelets with irregular borders, circulating micro-megakaryocytes, megakaryocyte cytoplasmic fragments and bare megakaryocyte nuclei are often present. Dysplastic and hypergranular neutrophils may be also present. Pleomorphic blast cells with high NC ratio, cytoplasmic blebs and basophilic cytoplasm in peripheral blood of a patient with AML-M7. Dysplastic and large atypical platelets with irregular borders in peripheral blood of a patient with AML-M7. Circulating micro-megakaryocytes are about 7 to 15 micrometers in diameter, with a pale blue cytoplasm and smudge-like nuclear chromatin. Micro-megakaryocytes often present platelet blebbing and cytoplasmic pink granules. Megakaryocyte cytoplasmic fragments in peripheral blood of a patient with AML-M7. Peripheral blood films of a patient with AML-M7, showing bare megakaryocyte nuclei. A normoblast and a megakaryocyte cytoplasmic fragment are also present. Peripheral blood film of a patient with AML-M7, showing a blast with high NC ratio and scant cytoplasm, a large platelet and a megakaryocyte cytoplasmic fragment. Peripheral blood film of a patient with AML-M7, showing thrombocytosis, a large megakaryoblast with blebs, a megakaryocyte cytoplasmic fragment, a large platelet and a bare nucleus. In AML-M7, blast cells comprise at least 20% of bone marrow nucleated cells, of which 50% or more are megakaryoblasts. The marrow picture is variable, and the bone marrow exhibits an infiltration with pleomorphic megakaryoblasts, and often blast cells in clusters. Binuclearity, cytoplasmic budding and dysplastic changes are often present. Variable reticulin fibrosis may yield a dry tap. Bone marrow film of a patient with AML-M7, showing pleomorphic megakaryoblasts with pale blue-gray to basophilic cytoplasm, high NC ratio and cytoplasmic blebs and pseudopods. Bone marrow film of a patient with AML-M7, showing pleomorphic megakaryoblasts with cytoplasmic blebs and a binucleated cell. Thank you for watching this video. If you liked this video, to give it a thumbs up and share it. Do not forget to subscribe to the channel, if you still have not. You can click on the bell to receive notifications whenever a new video is uploaded.